Good evening, everyone, and thank you for joining this dental learning webinar supported by SS White. I'm Joe Riley, the Director of Content for Dental Learning. We're pleased to have Dr. Rob Lowe with us tonight to discuss and demonstrate techniques to conservatively prepare and restore teeth using bioactive restorative materials. Cavity liners and restorative materials now have the capability of helping to rebuild and remineralize affected tooth structure and help protect the teeth from acid attack. These bioactive smart materials also offer an interesting restorative option. A conservative approach for both tooth preparation and caries excavation will also be discussed. Dr. Lowe graduated magna cum laude from Loyola University in dentistry in 1982 and was a clinical professor in restorative dentistry until 1993. He maintains a private practice in Charlotte, North Carolina, lectures internationally, and publishes in aesthetic and restorative dentistry. Dr. Lowe is a member of the Catapult Elite Speakers Bureau and has fellowships in the AGD, ICD, ADI, ACD, IADFE, and ASDA. In 2004, he received the Gordon Christensen Outstanding Lectures Award, and in 2005, diplomate status on the American Board of Aesthetic Dentistry. If you have questions during the presentation, please type them into the Q&A window on your screen. As many as possible will be answered during the course of the presentation. If you experience any technical issues, type a note in the Q&A window and a technician will help resolve it. This webinar offers one continuing education credit. To ensure you receive your credit, please stay until the webinar has concluded. Early departures will not receive credit. Your certificate of completion will be emailed to you within about 2 weeks. Thank you again for joining us this evening, and now I turn it over to Dr. Lowe to begin this presentation.
Hello, I'm Dr. Robert Lowe, and welcome to this evening's webinar, Early Diagnosis, Minimally Invasive Preparation Technique, and Bioactive Restorative Materials, a new paradigm in restorative dentistry. The topics of discussion in this evening's webinar will include early diagnosis and detection of pit and fissure caries, updating a standard of care, infected and affected dentin. What is the difference and what needs to be removed? Comfort cavity preparation, how to perform conservative preparation without anesthesia. Streamlining the finishing and polishing of composite restorations. And finally, bioactive liners and restorative materials, helping teeth heal themselves. I always include a professional disclosure because I have the opportunity and am very grateful to be able to work with many different dental companies and manufacturers in performance testing, beta testing, designing, and working on many different products. Tonight's webinar, I would like to thank for the sponsoring of this program, SS White Dental. So let's think about it for a second. How accurate is a new Explorer? How accurate is your Explorer? After an Explorer has been sterilized numerous times, how sharp is the point of that Explorer? Or is it really a blunt probe? Can we really tell if there's active caries in a pit and fissure with a sharp Explorer, let alone one that's been sterilized numerous times? Is it time to say goodbye to the old standard, the Explorer? This is a quote from Lou Graham, the founder of Catapult Elite. So what about hidden caries? Should there be a concern? When I went to dental school back in the late 70s, early 80s, I mean, we were in the GV black, let's watch and wait. Let's wait for the lesion to get bigger, bigger, bigger until we can justify putting a 699 cold steel carbide burr on the surface of the tooth and cutting a GV black dog bone extension for prevention cavity preparation. We weren't thinking minimally invasive back then. We were thinking extension for prevention. So I think a lot of hidden caries and small caries lesions went undiagnosed and untreated for a long time. Here's a picture of a lower molar with some staining in the groove. I guarantee you the blunt probe, the old sterilized Explorer, doesn't stick in there. So is that cavitation? Is that an early caries lesion, or is that just stain? If we look at that tooth actually sectioned on a radiograph, no real radiographic evidence of caries. Of course, you know, pit and fissure caries is very difficult to diagnose on an X-ray. But here is a picture of that tooth sectioned that shows through that small little stain, quote unquote, we see the development of a significant carious lesion that is undetected both clinically and radiographically. So pit and fissure diagnostics. What are we actually looking at? This is a great picture to see things that all of us see clinically every day and we pass up in the hygiene room as needing treatment. White decalcification is a good indicator of hidden caries. What's happening with decalcification? We have bacterial metabolism, acidic, drawing calcium and phosphate out of the enamel, causing this decalcification, which is the early start of a carious lesion. Pit and fissure staining also can be a sign of early caries. And in the center, we see a compromised sealant that is not really protecting the secondary pits or fissures anymore, and staining and or decalcification emanates from that compromised sealant. So I think we really need to look closely when diagnosing these types of situations in our patients, because my philosophy is early diagnosis and treatment is much better than watching things get worse. So in looking at this diagram of an occlusal surface, we can see subsurface stain, we can see white hypocalcification or decalcification. These are areas that should be thought of potential pit and fissure situations that need to be treated due to hidden caries. The studies that have been out there, numerous studies, too numerous to mention, have been done on looking at dental caries and the diagnosis. X-rays and Explorers are rated very poor as diagnostic tools for occlusal surfaces. Visual methods and caries risk assessment should remain a standard of clinical diagnosis for occlusal caries. You got to put all the information together. You've got to be the doctor. Patients that have no caries experience, low caries index, very few restorations, that may have an isolated stain, this may be something that would be more comfortable in the monitoring phase until the next recall visit, if that's a good recall patient. If it's somebody that comes in when something hurts, then you might want to look a little deeper. 92% of teeth with subsurface stains and white decalcification have decay present. That's an alarming number. So how can we get better on the diagnosis end so that we can treat these early carious lesions minimally and conserve healthy tooth structure? That's really what this webinar is all about. So here we have three actual clinical situations. 15 distal occlusal pit that has a potential early stain, quote unquote, carious lesion. Number 31, an occlusal pit. And number 18, an occlusal pit. What's your protocol for diagnosis? If you see this patient in hygiene and there's no stick in that fissure, do you recommend restoration or do you watch it? Well, number 15 and 31 had slight sticks, whatever that means quantitatively. Number 18 had no stick. So what do? Do we take out the drill? Do we recommend restoration of 15 and 31? And do we watch 18? Maybe. What's the patient's caries risk assessment? Are there any other fillings? How's the home care? Does this patient come into your practice on a regular basis for routine maintenance care? And what does your patient want? I always ask my patient, you want to keep your teeth for the rest of your life? I don't think too many people answer no to that question. So I tell them early diagnosis and treatment is the way to go. We don't want to wait till something gets bigger until something hurts. So early diagnosis for me has always been an important aspect of patient care. And in our hygiene room for recall, we've been using Diagnodent, which is a caries detection device for pit fissure caries, for many years. Diagnodent actually is a 655 nanometer laser beam. And it quantifies the extent of the decalcification numerically. In general, if Diagnodent is reading 30 or greater, I begin to get suspicious. If it's less than 30, and the patient has very little caries experience, then I feel comfortable watching until the next recall cycle and checking again. Remember, you still have to be the doctor. Use your eyes, use your explorers, use your x-rays, and then check the pit and fissures with Diagnodent. Record those readings. If they're going up, that's not a good direction. If the patient has an isolated pit or fissure that has a 32 and they have no fillings in their mouth, I may watch that until the next recare cycle and see where that number's going. If another patient has a 32 or a 35 in a pit or fissure and they have 5 or 10 other teeth that have fillings in, and maybe they're not so good at recall, maybe they cancel appointments and maybe they come in once a year or once something hurts. Different approach for that patient. Recommend treatment. This is how you integrate diagnostics. So let's take a look at these 3 teeth. 15, distal occlusal pit, a 64 reading with the Diagnodent. 31 occlusal, 31 with the Diagnodent. And number 18 reads a 38. So based on the diagnosis with Diagnodent, these are all early decalcification lesions. And being above 30, yes, they're dark stains. No, there are no sticks with the Explorer. Drill or not to drill? My choice would be early intervention. Another diagnostic tool, which can be used to help diagnose interproximal caries other than the X-ray, is a tool called CarieView. CarieView uses transillumination technology. You can find carious lesions and cracks often not seen on X-ray. It can help identify recurrent decay. And actually, as a digital image, this can be stored in the patient's digital record. Being that it's a digital record, it could also be used for insurance documentation, something that you can back up your X-ray and clinical photography with when creating records for your treatment. The slide on the left shows a tooth that has a large composite filling and a suspicious dark area around the distal lingual cusp with some pitting around that marginal area. And when looking at that with Carie view, we can definitely see that that part of the tooth is ready to fracture and separate from the rest of the tooth. This could be something missed by X-ray or clinical exam without having the diagnostic capability of transillumination. This is also visual confirmation for both the dentist and the patient to help explain why you can't just put another filling in this tooth. It needs full coverage. Another diagnostic tool that's available, CamX Spectra, Fluorescence technology, gives you a fluorescent map of the occlusal surface. This is a Doppler radar for caries detection. Here you can see from the color scheme and the bar in the middle of the slide, sound enamel reflects green, and blue is the beginning of enamel caries. When you see red, that's deep caries, still in enamel. And when you get into the orange and the yellow, now we've got caries in dentin. So it helps quantify, as Diagnodent did, but it also gives you a map as to where and how deep the caries is. Picture is worth 1,000 words. So let's go back to our original cases. 15 distal occlusal pit, 31 occlusal, and 18 occlusal. Let's look at color maps with Spectra. Quantifying the lesion beyond the scope of Diagnodent. Well, here we can see we've got some early decay in enamel in a couple of areas, and you can see decay into dentin in that distal pit. I don't remember, did that stick or not stick? Maybe it was a slight stick. Here's deep dentin decay in, I don't know whether this mesial distal, but it's proximal pit of that molar, and some early enamel decay in the opposite end of the occlusal table. And when we look at the slide on the right, we can see definite deep caries there. So what is the treatment? Minimal preparation with a fissurotomy burn. We're going to get into fissurotomy and comfort cavity preparation because in today's world, at least in my opinion, early diagnosis and treatment, saving healthy tooth structure is paramount to good treatment. We don't want to watch and wait for lesions to get bigger. We know that there's nothing that lasts forever, so that patients, if they want to keep their teeth throughout their lifetime, we need to be on the minimally invasive early diagnostic bandwagon and help them do so. To drill or not to drill? How do you decide? What's your office protocol? As I said, my decision here was to treat early and preserve tooth. Here you can see fissurotomy was done, teeth are restored, occlusion is checked. Really hard to see where the restoration is in the tooth. We'll get into this process in a lot more detail in following cases. So let's talk about this comfort cavity preparation to fissurotomy as a conservative treatment for dental caries. Because I really think, you know, I grew up in dental school on the GV Black extension for prevention. Today's rule should be prevention of extension. Early diagnosis, using as small instruments as possible, and using materials that will help heal and restore the tooth, not just fill a void. This is a picture of the comfort cavity preparation kit from SS White. This kit includes all of the burrs that you will need for minimally invasive caries exploration, for dentin excavation, for restoration removal, for trimming and finishing of composites, and for polishing of composites. The Great White Burr is a cross-cut fissure burr designed specifically for the removal of failed amalgams, PFMs, and all non-precious metals. Great White Burrs have been shown to save 5 minutes or more in restoration removal time because they cut through metallic materials efficiently and quickly. We're going to get into a little bit about preparation design, cavity preparations, because standard GV black preparation causes us to remove a lot of healthy tooth structure at the expense of removing clinical decay. You see a traditional round burr on the right, or a inverted cone, or pear-shaped burr, or whatever your burr of choice is for doing an occlusal cavity preparation. Versus on the right, you see a fissurotomy burr, uniquely designed to remove a minimal amount of tooth structure and gain access to carious lesions. This is an interesting slide to discuss cavity preparations and the amount of tooth structure that's actually removed when comparing fissurotomy burrs and traditional armamentarium. Looking at the graphic on the top of the diagram and comparing the volume of tooth structure that's removed and comparing a fissurotomy burr versus a 557, for example, at a depth of 4 millimeters, you can see a fissurotomy burr removes 0.927 amount of tooth structure versus 3.083 of tooth structure from a 557. Now that's in cubic millimeters. So that's 3 times the amount of tooth structure removed that's unnecessarily removed in many cases for these type of early lesions. When you look at the graphic on the bottom, comparing a fissurotomy burr to a 330 pair, which is again a common burr used by minimally invasive quote-unquote preparation procedures, you still, with a pair, have over 3 times the amount of tooth structure removed at 4 millimeters of depth. So think about your minimally invasive techniques and how much tooth is actually being removed just by the shape of the traditional burr that you're using to cut these preps. When removing decay in dentin, studies show SmartBurs II cuts decay but not healthy dentin, therefore avoiding inadvertent pulp exposures, but also avoiding removal of healthy dentin. Now in dental school, we're taught to excavate with carbide steel round burrs, which cannot differentiate between infected dentin, affected dentin, or healthy dentin. So we end up removing a lot of healthy tooth and material that could be remineralized and turned back into healthy dentin. The unique feature of the SmartBurs II is that it's a polymer burr. It's designed to have the same noob hardness of healthy dentin, so that once healthy dentin is engaged by the flutes, healthy dentin does not cut. That's the key to SmartBurs. Here you can see a diagram and showing penetration using a fissurotomy burr into the enamel and going down toward a carious lesion in dentin. The noob hardness of enamel is 360 to 440. New hardness of a carbide steel burr is 1600. Infected dentin, the caries we want to take out, 0 to 30. Healthy, unaffected dentin, between 70 and 90. This is where SmartBurs is really smart. We can get in with a SmartBurs, and I usually will use RPMs on my electric handpiece between 6 and 8,000 RPMs. You don't want to go too fast. But the nice thing about this is you're not going for a second and stopping and looking, going for a second, stopping and looking, hoping you don't have an exposure, wondering if you got all the decay out. That's what happens when you're using a carbide steel burr. With a SmartBurs, you put the burr into the lesion, you put your foot on the pedal, and you move the burr around until none of the stuff comes out anymore. And then you're done. The SEM on the left shows decay removal after using a carbide burr. And you see open tubules. And you know what happens when there's open tubules. Fluid movement in the tubules, and the patient perceives discomfort. So that's why for carbide burrs, most of the time when you're cutting into dentin, you will want to have the patient anesthetized. Here we look at an SEM view of dentin that's been cut with SmartBurs II. SmartBurs II, because of the unique feature in cutting only infected dentin and not cutting in the same way steel does, it actually smears the smear layer around and plugs tubules and burnishes affected dentin into those areas so that there's less possibility for movement of dentinal tubule fluid and eliciting a pain response. This is one of the reasons why SmartBurs II can be used to excavate carious lesions many times without the need of anesthesia. Patient trials have been done using SmartBurs II. 95% of these dentists rated the removal of decay as good or excellent. 97% of the cavity preparations were successfully completed without the need for anesthesia. 100% of the dentin removal resulted in no pain without the use of anesthesia. This is big, because if you can do this for a patient and not give them a shot, that takes away one of the barriers of patients getting treatment. Now, just a side note, in my clinical experience, I always give the patient some psychological anesthesia. And that is, look, Mrs. Jones, 9 times out of 10, I can perform this procedure on a patient and not have to get them numb, not have to give them a shot. If you're that one person out of 10 that experiences discomfort, you just let me know. I'll stop and I can use my anesthesia and complete the procedure. But just the fact that so many people can get this done without having to go through that, it's a big benefit to both you and your patient. A 9.5 rating on the comfort level, that's pretty good. I never tell patients that they won't feel a thing. I tell them, you know what, you may feel a little bit of coldness, you may feel a brief sensation, but it's not going to hurt. If it hurts, we can always do our backup procedure. And every time that I do this for a patient afterwards, even if they had 1 second of, oh, I felt a little something, I'll ask them, would you have rather had an anesthesia? Would you rather had a shot for that? Oh, no, it wasn't that bad. Most patients, not only do they not like getting shots, but they don't want to leave the dentist and be numb for hours afterwards. 100% of the patients surveyed preferred the technology to an injection. Not surprising. People don't like injections. A University of Maryland study concluded that the use of SmartBurs is an efficient method of removing carious dentin, and preserving caries and unaffected dentin, conserving healthy tooth structure. This increase in patient satisfaction and time savings, I think, is huge, not only from a practice management standpoint, but from a patient comfort standpoint as well. And just to look at a graphic, I'm a clinician, I don't look at numbers too much, but you know, if the average doctor does 1,000 cavity preps a year, and you could do a large percentage of them without anesthesia in a minimally invasive fashion, think about the chair time savings, think about the value to you and your patients, and think about how many of these patients are going to tell other patients, hey, I went to Dr. So-and-so, and they took care of my cavities, and I didn't have to have a shot, and I had a good experience. This is the way we build practices, and this is the way we build happy patients. One other thing I want to mention with fissurotomy is marginal composite repairs. My good friend Dr. Ron Jackson uses the word renewing. Composite is a renewable material. Amalgam is not. If amalgam or gold have a faulty margin, bacteria can swim around the entire restoration because they're not bonded to tooth. Composite is bonded to tooth, bonded to enamel and dentin. And if there's a little bit of stain around a Kavo surface margin from an incompetent margin, a lot of times this restoration doesn't have to be totally redone. It can be renewed using a fissurotomy burr with a flowable composite. Composite finishing burrs, two different ones, a 12 blade and a 20 blade. Let me just make a statement here too. In finishing composite, I prefer carbide over diamond. Diamond finish porcelain. Diamonds on composite create an orange peel type of surface texture. Smoother, better surface texture on composites, I feel, is gained using a carbide finishing system. The 12 blade is ideal to efficiently shape and contour. This is removal of excess, marginal finish, creating anatomy or refining anatomy. And then the 20 blade is ideal for pre-polishing. It's going to give a smooth, textured surface that once it's hit with the polishing cup, point, or wheel, it will give a luster to that composite very quickly. The polishing is shown here with the jazz point and the jazz cup. Again, these are one polishing, one-step polishers. You build up a little bit of slurry with some water spray. I like to use an electric handpiece with water spray when doing all composite finishing and polishing. And using this one rubber finishing point or cup that has been preceded by the 12 and 20 fluted carbide finishing burrs will give a beautiful luster to any composite. Jazz Supreme polishers will allow clinicians the ability to create a highly reflective gloss in one step. Next, let's look at cases with fissurotomy and bioactive restorative materials. Some of the key features of a fissurotomy burr. Actually, a fissurotomy burr looks like a depth gauge. Because of the cutting surface being 2 millimeters, you know exactly when you're at the DEJ, because most enamel on occlusal surfaces is about 2 millimeters in thickness. There are 3 different sizes. The original size shown on the top, the micro NTF, which is shown in the middle, which are used a lot in very tight, steep fissures, so we don't have to remove a lot of excess tooth. And then the micro STF that gives you a little bit less cutting surface, only 1.5 millimeters, for all the enamel type lesions. So here we have a clinical case. What do we see on the second molar? Maybe a little bit of darkness, no stick. we see a definite area that can stick with an explorer in the lingual groove on the first molar, verified with Diagnodent in the second molar that that tooth needs to be treated. Caries is excavated. I open up the caries lesion with the Fissurotomy burr, then use the smallest SmartBurs II to remove any infected dentin. And in this case, we use the acid etch protocol, bonding, and composite material to restore. And when we look at the restorations in the lower right, it's hard to even see where the teeth have been invaded in any way. Here's another case. You can see on the upper left the red circles depicting areas of hidden caries that have been diagnosed again with Diagnodent. And on the right, you can see the small little preparations made in those areas versus the outline which you see of the typical GV black class 1 cavity preparation that we were taught in school. So you get an idea of how much tooth can be conserved. We don't have to join them all together. If some of these fissures are not stained or carious, we can do separate preparations like we do and like you see on the upper left. Now the slide on the bottom is going to be a video that you will see in the next slide showing, just for a few seconds, use of an electric burr or electric handpiece with a Fissurotomy burr in cutting the preparations that you see on this first molar of this patient. Once the restorative material has been placed, now we will start the contouring and pre-polishing of the restoration. Even though these are small, remember pit and fissures are very sharp and tortuous. Most of the time you get pretty tight occlusion from the opposing dentition, and you'll need to check with articulating paper and do some minor adjustment. That's why the particular contour and pre-polishing burrs from the Comfort Cavity Prep Kit, we have very thin, narrow, pointed burrs which can gain access to these fissures and not polish or take away healthy tooth in the meantime. So we'll use the thinnest available 12 blade to remove excess and remove hyperocclusion from any area of the composite that needs to be removed. Once the occlusion is established to be good, then I'll take the 20 blade and use it as a pre-polishing step to refine and get ready for the rubber polisher. The two videos in the next slide will just give a couple of seconds of those two procedures being done. First the 12 blade, then the 20 blade. The slide on the right, on the bottom, you see the completed restoration after finishing. I've circled the two jazz polishers. For fissurotomies, most of the time we'll be using the pointed jazz polisher, the one on the left, not the cup. The video that follows will just show a couple of seconds using the jazz polisher on this particular restoration for this patient. Here's a couple of teeth on the maxillary arch. You can see staining. Do we treat? Do we not treat? Does it stick? No, it doesn't stick. Do the Diagnodents show that there's lesions there? Yes, they do. We check with Diagnodent, and we do Fissurotomy preparations. Slide on the bottom shows these restorations completed with a bioactive composite material. Let's continue now with a little bit more of a discussion on SmartBurs II and bioactive cavity lining agents, because this whole story is important as far as the diagnosis, the minimal preparation, the conservative decay removal, and differentiating between infected and affected dentin. Affected dentin can still be remineralized when calcium and phosphate are available. Here we have a second premolar that looks pretty healthy when we look at it clinically. When we look at it radiographically, not so good. I will do my initial entry into this tooth with a Fissurotomy burr, and then as the caries progresses buccolingually, I'll need to open up the convenience form and access form of the cavity preparation a bit so that I can visualize and remove the decay in the distal. One nice thing about SmartBurs as well is you don't have to visualize everything. You just need to have access form. Because the SmartBurs won't cut healthy dentin, you don't have to watch every bit of the decay being removed. Normal procedure would dictate opening up that lesion so that you have healthy tooth structure and dentin around all the decay so that you can make sure you get the decay out. Not so with Comfort Cavity Prep Kit. So using the SmartBurs, infected dentin is removed. You still may have a little bit of leathery scrape. You may get a little stick with a brand new Explorer, but this is affected dentin. It can be remineralized. So a bioactive cavity liner is placed, something like TheraCal, LC, or Activa. This is a sighting from Graham Mount back in Australian Dental Journal in 2007, where he was discussing a new paradigm in operative dentistry, which really wasn't that new. It's called remineralization. So we don't have to remove every speck of decay. Remember, decay is infected and affected dentin. Affected dentin can be remineralized. It's all over the literature. Here's TheraCal LC. TheraCal LC is a light-cured, resin-modified calcium silicate pulp protectant liner designed to perform as a barrier and to protect the dental pulpal complex. TheraCal is a material that can be used for both direct pulp cap and indirect pulp cap. Activa, which I mentioned, which is also a bioactive liner, Activa base liner, is indicated for indirect pulp cap. Both of these products have calcium and phosphate available and can remineralize affected dentin and turn it back into healthy tooth with calcium and phosphate appetite. The calcium release affects mechanical sealing of the pulp, hydroxyapatite formation and bridge formation, The alkaline pH helps promote healing and appetite formation. And one of the things about TheraCal that's unique is moisture-proof seal. We know that moisture is a problem in breakdown of the dentin bond over time. This is moisture from the dental tubules. So having a good seal is important for long-term success. So here's the patient after the TheraCal has been placed. The composite has been built up. Now doing the contouring and pre-polishing with the SS White finishing Burs from the Comfort Prep kit. And then follow polishing with the Jazz Polisher. Here's a radiograph of our completed restoration, which is really like a sandwich technique. Materials like TheraCal and Activa can be used as open sandwich, much like we used glass ionomer for many years. Just depends on whether you have enamel at that gingival margin on the class 2. In that case, I'd have composite there. If we're on root structure, you get a better seal with a glass ionomer type material. And here's the completed restoration. Here's another case that's similar. Small innocuous lesion turns into a big excavation. We start with the Fissurotomy burr. Open up small access form, use a SmartBurs to gain access and remove affected dentin. In this case, we had to open up the access form a little bit more, even use a diode laser because I needed to get a good seal with my matrix. Continued excavation. And here's a sectional matrix placed. This is a Garrison Compositite 3D. I really like sectional matrices for composites because you're going to get more consistent contacts, and you can see the seal of the matrix around the cable surface margins is much better than can be performed with a Toppelmayr type band. TheraCal is placed. And the tooth is restored with composite, and now we'll see how the patient responds to therapy. That may end up being a composite core and a crown later. It may not. Just depends. Here's a case of extract or restore. When is heroodontia an option? Now, I mention heroodontia or heroics because bioactive materials are changing the way we think about treatment in some cases. Biodentin, or tricalcium silicate, is a bioactive dentin substitute. We've already mentioned bioactive liners, cavity liners, and bases. This is a bioactive foundation material. I mentioned heroodontia because, again, this is similar to TheraCal, and if there's a minor pulp exposure and a large restoration was removed prior to doing a crown preparation, biodentin can be used as your build-up. You put a temporary on and see how the tooth responds to therapy. If there are perforations looking for calcified root canals, biodentin can be placed and see how the tooth responds to therapy. Not always an automatic extraction. Internal resorption, external resorption, same thing. It gives the tooth a chance to heal. Here's a case, crown and bridge case, where there was an external resorption on a facial margin. The rest of the teeth were prepared and temporized. Once the temporary was cemented, a small full-thickness mucoperiosteal flap was elevated in the area of the resorption, and Biodentin was placed into that defect. The slide on the top shows a 6-month follow-up. There is a probable sulcus, and what I'm assuming would be a hemidesmosomal attachment similar to an implant. But tissue health, the tooth has been saved. Root canal was done so that there's a root fill in this tooth and the tooth is restored. This has now been 3 years, probably 4 years post-op on this particular tooth with external resorption. On an oral surgeon, when I asked him, you want to take the tooth out and do an implant? What do you think he said? No. So these bioactive dental materials, the future is now. Ceramide crown and bridge is a crown and bridge cement used to cement anything from zirconium to high-strength ceramics like Emax to PFMs. And this cement is different from any other crown and bridge cement because apatite forms on the surface of the cement in the presence of saliva. We already discussed TheraCal as a bioactive cavity liner, and Biodentin as a bioactive crown and bridge buildup material. Activa, we mentioned Activa base liner. What's shown here is Activa Restorative, and we'll discuss that in a future case coming up. And then a unique composite on the market from Shofu. This is BeautyFill Flow Plus. It's a GIOMER technology that's incorporated into this composite that uses in the glass particles of this composite. They're coated with a layer of a glass ionomer type phase that is then protected with a harder coat so ions can be released from this material over time. Why is bioactivity so important? Well, you can read the first 3 sentences here on the slide about the biologic activity and affecting and eliciting a response. The important thing for us in dentistry is biomineralization, the exchange of calcium phosphate ions to form apatite. That's really what bioactivity is all about in today's world. It's not just hydroxyapatite being changed to fluorapatite. Bioactive materials are dynamic. They're considered to have smart behavior if they have the capacity to interact with living tissues or if they can react to changes in the oral environment. And we know that the oral environment is constantly changing. Bioactive materials also react to pH cycles. When the pH is low, demineralization happens and calcium and phosphate ions are removed from the tooth. When the pH rises, these ions can interact with fluoride in the saliva and precipitate onto the tooth surface and form acid-resistant fluorapatite. This also happens internally when talking about cavity liners and bases because of the fluid and the availability and ion availability in the dental tubular fluid. So let's look at this Activa material from PulpDent as a bioactive restorative. With Activa, there's a continuous ionic release, uptake from the material and the tooth. I term Activa or describe Activa like a battery. It is a storehouse of ions. If the tooth needs ions from demineralization, it pulls the ions, the calcium and the phosphate from the Activa, which can then be resupplied from the saliva, food, toothpaste, water, or as I said, on the bases and liners from the dental tubular fluids. And this ion exchange between the acid groups and the ionic resin occurs at a molecular level. But the interesting thing about Activa as a restorative material is that while it might be an RMGI, but it's really not because it's a little bit different chemically. It thinks it's composite, but it's not. It's really a very unique material. And if you look at some of the studies that have been done in the lab, this one, compressive strength, done at Tufts in 2014, notice on the far right, Fuji 9 is a standard for glass ionomer, straight glass ionomer, and many people use that for buildups. Filtech, 3M Filtech is a composite. There are many good composites out there. And comparing the compressive strength of composite versus the compressive strength of a glass ionomer, you can see the difference. Well, Activa is very similar, only a little bit less in compressive strength when compared to composite. Let's look at wear rate. This is really where I think the rubber hits the road, so to speak. When you're comparing a straight glass ionomer like Fuji 9 on the left, and you can see the wear rate in millimicrons, and then you look at the wear rate of Tetric Ivoceram and Filtech, which are composites, Activa wears like the composite. So it's a bioactive material that thinks it's an RMGI but might be a composite. We don't know, but it has the benefits of both. Where does that come into play in my practice? Root surface decay. Always used to be a glass ionomer area for me, but now it's Activa, and not just because of the calcium and phosphate availability, but also because of the delivery. The delivery of Activa is in a dual barrel syringe with an automix tip and a metal cannula that you can bend to gain access to these difficult areas. Whereas part of the problem with glass ionomer technology is the delivery and confining the material and finishing and polishing the material. This is heroodontia again. I've got an old patient with a long span bridge, mesial decay on that distal abutment. And what's your treatment plan? Extract and implants? Well, she can't afford that. Unilateral partial? Not great. Why not try saving that tooth and extending the life of that bridge? And that's exactly what we've done with Activa. Now, when we talk about the world of bulk fill, Activa is a bulk fill. You've got caries control patients. You can keep the preparation small. Get in with a SmartBurs and excavate that infected dentin and place Activa in a bulk fill. This is a dual cure, so you can light cure it and finish and polish. So talking about pediatric cases, caries control patients, patients with high caries incidence. You know, this is an excellent choice for those types of patients. Be the doctor. Don't just use one material for every hole that you fill. You've got to really look at what the clinical situation is and pick the material that's appropriate. So this next case we'll discuss in detail the GIOMER technology with Beautifil Flow Plus. So what is a GIOMER? GIOMER is a glass particle, glass core, that's got a glass ionomer phase coated with a glass ionomer material that is subject to have ions that can be released into the environment. And there's a surface modified layer on top of that so that this just doesn't all dissipate quickly. In a nutshell, a GIOMER is a composite that has ion release. Clinical benefits of a GIOMER: formation of acid-resistant layer, reinforcement of tooth substance, remineralization of dentin. The big thing here with ion release is anti-plaque effect and acid buffering capacity. So again, patients that don't know which end of the toothbrush have the bristles, particularly in the class 5 areas where decay around the gum line and plaque accumulation is frequent, this is a good material to consider. Here's some class 5s that I'm showing with air abrasion. This is using Prep Start from Danville. That's bad dentin on these types of abfractions. So we need to make that bad dentin a little bit better for adhesion. I also use a fissurotomy burr to put some mechanical retention in the gingival floor. This is what I call a smart class 5. And a selective etch technique on the enamel. Here we can see preparation complete. After etching, placing the bonding resin. The first layer into the preparation is with the Beautifil Flow Plus. This is going to give the GIOMER ion release and adapt to the margins very nicely. The second layer is with the traditional nanomicrohybrid Beautifil, the paste version, to build out the contour. Here's the finished result after finishing and polishing. Here's a couple of other examples of GIOMERs placed in class 5s. Beautiful disappearing material with ion release and margin protection. Another class 5, if it goes a little bit subgingival for decay removal, I use a diode laser. This is the AMD Picasso. So we can get the tissue out of the way, make the gingival margins supragingival, control any hemorrhage. I wouldn't recommend placing cord in there to try to push the tissue away and do a composite. You'll get the cord stuck in the composite. Diode laser is the way to go. And then using Beautifil Flow Plus and traditional Beautifil to build out the cervical contour. Light curing, finishing first with the 12-fluted contouring, and then followed by the 20-fluted pre-polish and the jazz polisher. You can see a beautiful finish to that Smart Class 5 composite. Lastly, a slot prep for a Class 2 using GIOMER. Here we have a very small, minimally invasive Class 2 preparation, and we can see the carious lesion and decalcification. Isolation is performed with isolite, and then sectional matrix. The Comfort Cavity Prep Kit also has some nice slot burrs for performing these minimally invasive Class 2s. Here we can etch and bond, light cure. And in this case, I'm using Beautifil Flow Plus, the bulk fill flowable, because of the depth of this lesion being approximately 4 millimeters from the gingival floor to the Kavo surface marginal ridge. I'm using a bulk fill flowable in this small preparation to complete this process. Here's the restoration after it's light cured and the matrix removed, good contact, minimally invasive, restoration complete. It's been an enjoyable hour. We've talked a lot about diagnosis, minimally invasive cavity prep, design, comfort cavity preparations, bioactive materials. I am a big music fan, and Rush has always been one of my favorite bands, whom unfortunately have since retired this year. But there's still hope. There may be another studio album in the works. Here's me playing guitar at age 12 in Chicago, and with one of my dental bands from the American Society for Dental Aesthetics in 2012, and then again in 2013. That's me over there on the right with the dark hair that time, as opposed to the other picture. But again, thank you so much for your kind attention. I've enjoyed spending time, and if you have questions, we're going to entertain some questions for ones that we have time. Otherwise, you can send a question to boblowedds@aol.com, and I'd be happy to respond. So let's quickly take a couple of questions that have come from the audience. Number one, describe the process of comfort cavity preparation as opposed to traditional cavity preparation. Well, in describing that, it's very simple. It involves a couple of things. First, early diagnosis allows us to use minimally invasive armamentarium, like a fissurotomy burr, for example. And excavating in dentin with a polymer burr that is the new hardness of healthy dentin allows us to be minimally invasive in removing infected dentin only and rebuilding the tooth with bioactive materials. The fact is that a lot of times, because of this approach, we can perform this in a minimally invasive and comfortable way without anesthesia. And that is a real benefit to patients. Let's look at another question. What is the difference between bioactive bases liners and things that are available today versus Vitrabond and liners, GI light-cured liners like those that have been used in the past? Can I still use those? Well, the answer is yes. Those are very good materials, and they've been around for a long time. The story I always use is, the horse and buggy was around for a long time too, but we decided to go to automobiles and airplanes. I mean, we're talking about technological advances. I think sometimes we as dentists, we get into this, well, I used this for years and it worked type of thing. The traditional glass ionomer or resin modified liners, some of them have fluoride release maybe for an hour, some a day, some a week, some a month. Some are better than others. They're still better than the copolites and calcium hydroxides of years past, but they don't have the benefit of replenishing calcium and phosphate in debilitated dentin that's demineralized. So these types of materials, I think, are on the forefront, and we will see more of them as we go forward in dentistry. That's all the time we have for questions. So again, I would like to thank you very much for attending this webinar, and thank you to SS White Dental for sponsoring this webinar for us. And if you require any further information, would like to contact me, again, that email address is boblowedds@aol.com. Thank you so much for attending, and have a good evening.
Thank you, Dr. Lowe, for answering those questions and for your presentation this evening. Unfortunately, we've run out of time for Q&A tonight. Any unanswered questions in the Q&A box will receive a reply by email in the next few days. You will receive your CE Certificate of Completion for tonight's event in about 2 weeks. For more CE opportunities, please visit www.dentallearning.net. Thank you again for joining us, and have a wonderful